All right. Well, if I haven't met you, I'm Anthony Maloof. And Westmead Private asked me to give a talk, and I thought, my sister works in general practice, and I asked her, and she just reminded me of the problems that she sees, and I went, difficult problems you guys see. So that's why I called it that. I'm very informal with my talk, so just stop if you've got a question. If I go too fast, if I say something, if I mumble, just stop me. I trained in ophthalmology and then into oculoplastics, and my area of practice is in cornea, front of the eye, oculoplastic surgery around the face, hence the practice is called Eyes and Faces. My area is limited to some advanced surgery in that area. I consider myself a reality surfer. I am not politically correct. I've decided that I would rather approach things from the reality point of view. I will sugarcoat my treatments when nature sugarcoats disease, and that's what I tell my patients. Until then, it's pretty direct. So what do? I don't do any general work, but what my area is sort of a joining of the front of the eye ophthalmology. I spend half my time up the nose, so I sort of intrude on the ENT guy's world. I've got scopes coming out of my rooms all the time. And then plastics onto the face. It's sort of like a fixer. I could run a patient by you that I literally just saw before coming here, very complicated, problematic. I like that sort of stuff. I work in the city, I work here at Westmead, offices in the city and Westmead, dedicated to this. I used to work at Westmead Hospital, ran it for 12 years, left after I realised that it was a hospital built for administrators rather than patients. And now I work at Prince of Wales, and you've probably experienced that, I'm sure. Prince of Wales Skin Hospital, Sydney Hospital. So what is this? If I were to explain what I do, this would be it. There's a pot of gold with your name on it. Okay, it's there. As much gold and platinum as you want in it. It's down the street. Go down the street, look for the large house, turn right. Keep going till you see a tree. Turn left, 100 metres down the footpath, start digging. I'll bet none of you could find it. And what I tell you that story is, to me, it's the problem of invisibility in the area of the unknown. And I tell my patients that and they understand. You guys, if you're lucky, like me, had 2 weeks of training in this area, which you've forgotten 2 weeks after you did it. And now you're supposed to practice in it, and patients will ask you questions that they will ask me and expect the same answer from you. Hence, I'm not going to go into all the finesse, just simple stuff to get you through it. So you don't see it, it's invisibility, and it took me 2 decades to understand that concept, and it's key. And when I tell it to patients, they go, oh, okay. So, you will be familiar with patients with pterygium. You could probably describe it. Patients will have come to you and said, I don't like my eye, but you're thinking, what is it? Am I missing something? People will say their eye waters. People come in with thyroid disease. What happens with those patients? Skin cancers. What do you guys do? You treat lots of skin cancers. What about around the eyes and upper face? What do you do? People have had a transplant. What do you do? Scars, I didn't go into details because I thought I would run out of time. But of course, steroid drops. I always get asked about it. What should GPs do with steroid drops? So I thought I would limit it to that. So this is what I realised about patients. They differ by what? What they think, what they feel, what they say, what they express, and what they can't recall. Okay? So I thought I would treat the conditions by what? What's the condition? What does it look like? What should you look for? What you can do? What needs referring? And then what I do. So a pterygium. Everyone asks, what's a pterygium? It's basically a scar. It's a scar. There's heaps of causes. UV light's one of them. This second line here, I'd like you to look at because you're going to see it in every single slide. I don't go by patients' symptoms. In fact, I tell patients up front, most of you don't know eye symptoms. You'll tell me the wrong thing and misguide me. So everything in the eyes causes redness, discomfort, blurring, irritation, go on and on and on. And you'll see that only over time. People come in and they hate their pterygium. We live in a vain world. We've got social media, we've got pictures. There are a whole lot of things people complain about. Droopiness of the eyelids, heaviness, skin changes. Pterygium's one of them. For those of you who wear sunglasses, how many wear wraparound sunglasses? Full wraparound. I'm talking big side rims all the way around. So you do? Anyone else? There you go. I don't step outside without them. Okay? Because all the light from pterygium comes from the side or behind you. So all the designer glasses you buy are useless if you really want to want eye protection. Mongolian sunglasses, actually the Mongols demonstrate physical adaptation to a UV environment. Us people that don't have that appearance are not as adapted. So,
Is that the cause of pterygium?
huge light focusing problem, light from beside you or behind you will focus into the corner of your eye and amplify the UV light by 20 times. So whatever your ambient light is, I did my thesis on that, UV modelling, it will focus across. So it's a huge cause. Huge cause. And there's different aspects and people who are at more risk of that. People with flatter nasal ridge will get temporal pterygium. Okay? So I actually don't go outside without my wraparounds. Everyone knows what they look like, but what you don't know is that quite often on the surface of these, there are nasties, and I'll explain that to you. But look, if somebody comes into you and says, hey, listen, I don't like this, what do? So it looks like that, and if it's on your eye, you'd hate it. And they come in and go, don't like it. Vision's fine, don't like it. So what have you got to look for? How big, how red, how troubling? And just, I cannot say enough in medicine. We love to give you a black and white box. Do this, 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 and this. It's a silly way of looking at it. You'll have seen enough patients. If something's not right, it's not right. Send it, right? If you ask the patient a question, has it changed? No. Okay, look at it. Doesn't look too bad. You're probably okay. You're probably not sitting on a dangerous item. But the patient will tell you, you've just got to ask the right questions. So what can you do? Very straightforward. You could ask them to check vision, just a handheld Snellen chart. If it's okay, it's fine. If it's down, send them off. Please, the wraparound sunglasses for yourself. I've got some material I'm producing for patients, and one of them's come up. We're going to do a photo shoot this Thursday to show that, because it's really important. Do you get hit with companies coming to sell you drops and tell you about drops, lubricants? Patients will ask me, what lubricant should I use? What drop should I use? I call them comfort drops. Okay? That's what they are. They're moisturizers for the eye. One's better than the other. Patients will tell you this one's better than that one. The next one will tell you the polar opposite. The rep will tell you theirs is the best. Look at all this rubbish research that they've done. Would you give a talk on it? No, go away. I tell the patients, go and try whichever one you like. Okay? They're just comfort drops. Astringents, I know you can give things Nafcon to take red out and all that sort of stuff. Please refrain from that. They're quite toxic. Please don't put preservatives in an eye, so get preservative-free drops. Preservatives, does anyone know what a preservative is? It's a detergent. So if you're willing to put your detergent in your eye, give your patient drops, preservative-free is the way to go. You're all used to topical steroids. If you see a pterygium, a bit angry, a bit sore, gives patient lubricants, they're not happy, try some FML, they're not happy, get something done. Really, that's all you have to do. You guys have enough to do and worry about details. So, I said to you, use your judgment. If it just doesn't look right, if the patient's complaining, tell you it's changing. If they're anxious or if there are appearance issues, you need to send it on. What do? Pterygium, we used to just cut it off. I remember when I trained, we'd take them to the clinic and just cut them off and send them away, and they'd come back and they'd be horrible. We even used radiation, and I'll show you a problem with that. We used radiation on the eyeball. There's all different techniques. Basically, it's a reconstruction procedure. You've got to do a big clearance of the pterygium and graft it, and I'll show you that. So that's a big graft. I don't know if this will work. If there's a laser pointer here, there we go. That's a big graft, okay? So the pterygium's cleared to the roots out here, and a big graft is placed, and then that'll settle down.
Sorry, that graft from where?
You take it up underneath the eyelid. If you leave that bare, it'll just come back. Do it that way, less than 1 in 1,000 recurrence. So it works. Yeah, it's a bit uncomfortable for a couple of days, so go back to work. We treat city patients, so you go back to work after a few days. So this lady, trooper, this lady comes in, she's about 80. She's got them in both eyes. And she goes, I don't want 2 operations. Fine. So I did both together. And there she is about 2 months later. Nice white eyes. You can see in the front of the cornea here's a little scar, because as it grows across, it scars the cornea as well. Didn't trouble her, didn't lose vision. Off she goes, she's happy. Okay, so that's the guidelines for pterygium, and that's all you have to do. It's really simple. It's written down. You don't have to worry about it. So here is a melt from radiation. Okay, that's a hole in the eye. so we have to patch graft it. So, you know, you can get problems, and you wouldn't like that. I wouldn't like it. But if it doesn't look right, does that look like a pterygium? They come in. I call this the stolen diagnosis. A patient will come and say, Doc, I've got a pterygium. And what do? You go, yeah, you've got a pterygium, you hand it back. They've given you the diagnosis, you hand it back. Okay? And I tell patients all the time, don't give me a diagnosis, let me work it out. So be very careful. If they walk in and say, I've got a pterygium, and you have a quick look and you go, yeah, it looks like a possible pterygium, there's something there, that's a cancer. Just look at it. If it doesn't look right, I don't want you to diagnose it. You don't need to diagnose it. It just doesn't look right. Use your clinical judgment. They come in all shapes and sizes, and here is big glossy cancer here. And here is a viral papilloma here, yeah, viral growths, HPV. By the way, if you've ever seen some of my patients come through, I will give these patients Gardasil. Just as a side, HPV is over all of your bodies, so don't think you haven't got it, it's there. HPV causes surface cancers, skin cancers. I give these people HPV and they shrink. It's amazing how powerful it is. It's not supposed to work in that condition, but it works. I've had it myself because I thought, Jesus, I'm going to take it myself because this thing is amazing. So if your patients come from me and never ask for the Gardasil, just give it to them. I'm going to move on. Every one of you would have had patients that said, my eye waters. Everyone. Has anyone here had a watery eye? Yeah? Drives you bonkers, right? And the thing about it is the problem of invisibility. They come in and you can't see it. I had a lady today came in, no, I kid you not, she came in and she wasn't sure. She described the symptoms. She described half of these and then goes, yeah, and occasionally it waters. And I was able to demonstrate the drops. One I was pouring, the other wasn't, but she didn't say that, all right? But she gave me a few pointers in the history. It's tricky. I've got a lady tomorrow that's had a watery eye, both sides. I treated one in 2012. She goes to the other one, oh, I'll put up with it. She shows up last Wednesday with an acute dacryocystitis infected. She's scheduled for heart surgery 2 days ago, and I went, you're not having your heart surgery. I'm operating on it tomorrow, and we're draining it. So they come back to you. So they complain of everything. They don't like it. And if you ever want to feel it, come over to the practice. I'll block 2 tear drains on one eye, and you can walk out and see if you last the week. Okay? So watery eye patients hate it. They absolutely hate it. And when you tell them there's a problem, that's half the relief. Oh, finally, there's something, we can fix it. Yes. Do you know what they come in saying? I've got dry eyes. What? I said, so tell me something. You got dry eyes. Did you put drops in your eye? Yeah. And what happened? Nothing. Then I demonstrate watery eye and I ask them, so if you've got a watery eye and you put more drops into a bucket of water, how's that going to make you feel better? And they go, no. But, believe it or not, if you've got a patient with watery eye, I'll tell you, try it. Just so you know. There it is, young people. So you put a drop in a fluorescein, and there it is. I show them the mirror and go, look, it's watering. They go, yep, watering. You want it fixed? They go, yep. I go, fine, we'll fix it. So there's a tear drain in the middle here. We all have a tear drain. It's a really, that's an amazing piece of engineering, the tear drain. I'm not going to go into it, but it's just an amazing piece of bioengineering. So there's a blockage somewhere there. Basically, it's surgery, we unblock it. The details are irrelevant. You just need to know that if it's got a watery eye, it's real. Okay, so what to look for? If you see a patient with watery eye, they look glassy. Look like they're crying. If you have kids and they cry, just look at their eye. It looks glassy. So that's what you should look for. And it looks watery, and you think, yeah, it's a watery eye. And the key, you know, how many times do you wipe your eye? Oh, every hour I do this. By the way, don't wipe your eyes. Don't wipe your eyes. It's really, really, really bad. And patients will sit there and do this and do this. Don't do it. Every person in this room rubs your eyes. Inadvertently, you're programmed to do it through evolution. Stop it. If you want to know why, look at our transplant website. There's a video on there, a couple of videos. You'll stop rubbing when you see it. So they wipe the eye. And also there can be eyelid problems. Does anyone know what that's called? Excellent. Have you ever had your eyelid rubbed in on your eye? It bloody hurts. Causes a watery eye. They might complain of a watery eye. It just hurts. So that's not a tear drain problem. I'll fix the lid. Be suspicious. If they're complaining of watering, it's probably watering. Okay? If something's not working, if they're complaining of dryness, it could still be watering. I call them, as I said, comfort lubricants. Just try it. See how they go. If you've got a friendly optometrist, they might help. One that will talk to you and deal with you. Some of them don't like to. Please don't rub your eyes. That goes for you guys as well. And for women, if you want the cheapest makeup advice, cheapest aesthetic advice in the world, don't rub your eyes. Costs you nothing. You can try steroids. I actually think you should. Believe it or not, you can give a patient a placebo, tell them you're giving them a placebo, say you don't expect anything to happen, nothing should happen, and give it to them, and they'll still say it helps. And that's well proven. So try it. You're unlikely to suffer any adverse consequences. I would give FML. I'm going to accelerate the pace, I'm running out of time. If they're anxious or annoyed, send them in. Eye-Fix, a tear drain, it's watery eye surgery, keyhole watery eye surgery, and anything else that's going on. Open up the tear drain inside the nose. There's the tear drain open with the probe through it. And there's a stone inside a tear drain. Yes, you can get tear drain stones. Okay, there's a stent afterwards, so we put a tube in and you might see that in the eye and they complain about it. Next one. You guys all see thyroid patients. Sorry if I'm moving a bit quicker. Thyroid eye disease, I can't stress to you enough. They will come in and you'll think it's allergic. They'll complain of puffiness and swelling. Most of my patients have been to a GP and told it's allergic. Puffy eyes equals thyroid disease until proven otherwise. If there's nothing else you remember, puffy eyes, please do your whole battery of thyroid investigations on every single person. Thyroid antibodies, thyroid immune, TSIs, do them. Okay, puffiness equals that test. You don't have to send them along, just do that and you'll find out so much. What do they come with? Note the similarities. They complain of everything. All right? The thing that happens, has anyone here had thyroid disease? You've seen patients with thyroid disease, you've shown your patients, right? It's a disfigurement, okay? Don't underestimate it. It's a psychological disease. And if you don't believe it, I wish it on you, and when you've affected, you'll see what I mean. It is a traumatizing condition. If you think they look asymmetrical, bulgy, eyelids look funny, they've got thyroid disease. Puffiness, you've got thyroid disease. Please don't jump to this diagnosis. They're not allergic, okay? So look at the bulge, see the stare, but look at the lid, look how it pops up there, look at the swelling up here. It's not allergic disease, okay? Please, 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 I'm begging you, do your endocrine workup, do all the stuff that you have to do. If you've got a friendly endocrinologist, whatever, but do your tests. And yes, the eyeballs pop right out of the sockets. Yes, I can decompress it. Here's the key, if we get onto them before this happens, you stop it getting this bad, okay? So here's a lady who doesn't have that. And she hates her appearance, hates it. Which woman in this room wants to look asymmetrical like that? I had a patient come in, didn't realise it, with her daughter. I told her, did you notice your eyelid was like that? I told her. 1 hour later, she walks out of the room, we're getting phone calls left, right and centre. She's freaking out, she's going blind. Because I pointed out to her, I had to take a photo, turn the camera and show her. She couldn't see it in the mirror. Once they see it, they freak out. And once they freak out, you've lost the race. So that's thyroid disease, lid retraction. Please do investigations, check your visions, look at the similarities. Use lubricants, try FML. Very simple. If it doesn't look right, if they're anxious, appearance, if what you're doing is not working, thyroids are all wrong, just send it straight off and we'll fix it. If they come to me first, I send them back to you to manage the thyroid, okay? I will give them radiotherapy to stop progression. It works, it's unbelievable, it just stops the disease dead. And if they're disfigured, I'll correct them with surgery, which is stereotactic navigation of the orbit, and we'll decompress them. So here's the lady day one, bulgy, day one, eyes gone back. And it's all through the nose. So, young people, he hated it, absolutely hated it. You could see, hated it, much happier. Obviously, you can see that anyone, you don't need to be a medical student to pick that, but it took us a while to get her back. We'd rather her not be there. This lady got chucked out of her wedding bridal party, somebody's wedding. So, I reversed that. Okay, any questions about that? Skin cancers, you guys treat them, you cut them out, you cryo them, you use P.E.R.F.E.C.T, you know what they look like. Can I please advise you, and I tell patients this, there are 3 answers in medicine. Correct diagnosis, I don't know, and bullshitology. And I offer 3 to my patients and say, pick which one you would like. And they all go, correct diagnosis. And I go, fine. What if it's I don't know? Then I'll biopsy. It's as simple as that. Okay? No one likes to have a skin cancer. No one likes it on their face. There's heaps. They're everywhere. We all know them. There's such UV widths. 80% of people are going to get a skin cancer. 80%. Okay? We can't treat them all. You guys treat them. All right? But they occur on the eyes and around the eyes. And everyone freaks out. In the end, that looks horrible. It's a spreading, horrible BCC. That looks much more obvious of nodular ulcerative BCC. Do you know what? If you have a 2mm punch, if you have proprioception, and I mean proprioception, don't sit there and shove the thing into the skin, very delicate, you could biopsy that and that. Okay? If you're too scared, send it along. But seriously, I wouldn't biopsy that. I'd go, yep, that's BCC, off you go, you're having Mohs surgery. But if you're not sure, just do it. I think you can't biopsy enough. Obvious? Not obvious. All right? You won't want a biopsy here. Don't. Just don't. Leave it out. But here, lower down, biopsy it. Put a little punch in it. Okay? Squamous cell carcinomas. Okay? Squamous cell carcinomas. Don't miss them. Please don't be the GP that says, oh, it's just a chalazion. Okay? It's just not right. Please just suspicion, detect, biopsy, suspicion, not able to biopsy, refer. And look, F.E.C.T on the face is great. Tell the patients it's like a chemical facelift and they will sign up for it straight out. Okay? They'll love it. What needs referring? Anything around the eyes, tear drain, anything doesn't look right. And if it's come back, please don't sit on it. Okay? What do? I'll confirm the diagnosis. I can cut them out. I don't. I work at the skin hospital. It's conjoint, Mohs surgery for everything. Okay, they provide a wonderful service. I was there yesterday. I was there. That's why I'm a bit late today. Was there today. Mohs surgery. Okay? And then we reconstruct all in one day. So big holes, they're great fun, and I like doing that. Things like that. Sorry, I like that. And this, this is the sort of thing where people can lose their eye. There's no orbicularis function. We want to keep this old lady seeing, taking her sight to the grave. Yeah, she's not going to be a catwalk model, but she's got vision. Cornea transplants. Sorry, have you got any questions about skin cancers? I want to reassure you, it's okay to take a little biopsy in the outer part of the orbit. In the inner one, fine, send it on. Take a biopsy, follow up. But please, if you're going to biopsy, don't shove it into the eye. It's been done by trainees. Okay, so just be very cautious. Just gentle. Any other questions on that? Any questions at all? All right. Do you have patients with a transplant? If you have patients that have corneal problems or transplants, there's so much that goes on. There's very little detail I'm going to give you except to say, again, lubricants and a bit of FML. It's a good start. They complain of all sorts of problems. Note the similarities, same thing. It's a bulgy cornea called keratoconus. You may have heard of it. People rub their eyes. Remember I said don't rub? They induce this disease. Okay? And they're legally blind. So for those of you that say, I didn't rub, I just wiped my eye. Yeah, you probably do that up here on the right, or that. Just stop and tell your patient to stop. This lady pushes on the top and gets a bulge in the cornea. Okay, so don't do it. This man is so obese, he's actually got proptosis from obesity. His eye rubs on the pillow at night. He has to sleep with goggles on. This guy was legally blind when he came to see me. He's happy to see. He's had to have special transplants. Corneas can rupture, okay? Don't rub your eyes. But there's also swelling of the cornea. You might see patients after cataract surgery, they're not happy, their vision is cornea swollen. We can correct all of that now, very straightforward. So people can get vision loss from eye rubbing, or they can have a cloudy cornea. I don't want to go into the details because it's very complicated. But basically, if you have a patient and got those symptoms, just send them along. Seriously, try your drops, try your FML. You're not going to run into trouble. Lubricants, preservative-free, try a bit of FML. They're not happy, just send them along. The longer you leave an unhappy patient, the more miserable and litigious they become. Okay? It's a rule of surgery. If you have a complication, fix it ASAP. That's a layered transplant. Another layered transplant there. That's a cell transplant for the cloudy cornea there. There's a cell transplant here, plus this gentleman had a fixed dilated pupil, so I put a little stitch in to bring the pupil down. This is nice. You might, one of these guys, this guy might be one of your patients who lives in this area. That's what he used to use for a train timetable. Now he uses the government one. I'm going to leave scars. We're running out of time. We've got about 8 minutes left. So final one I want to run by you is steroid drops. Everyone freaks out, okay? And it's true. The killer that will bite you with steroids is herpes simplex virus. 95% over 60 have HSV in the body. It's a nerve-based neurotrophic virus. The greatest density of nerves is the 5th nerve, and of that, most of it comes to the eye, okay? And here I am telling you to put steroids on it. Without going into what happens, if you're happy it's not a cold sore virus, try steroids. If you suspect, ask them the question, have you had cold sore virus? Yes. Don't give them an FML. And if there's one recommendation I can give you, it's that. If you think about giving FML, just ask them, have you had cold sore virus in your eye? No. Okay, try it. If it's not working, you can see it a mile off. Okay? Somebody has bacterial keratitis, honestly, I can get a 3-year-old to pick it. What's wrong with your eye, mummy? It's not hard. You guys know what a clear eye looks like. All right? But you've got to use clinical judgment. You've given them a one treatment test, get them back in a week or whenever, not better, okay, not responding. I tell all my patients with cornea and transplants, I give them a 24-hour rule. Straight out, I don't care when I last saw you. If you've got a problem, it doesn't get better in 24 hours, you get seen in 24 hours. And they just ring up and they come straight in. End of story. Okay, so I don't mess with corneas, but as I'm saying to you, try your lubricants, try your drops, just ask them, have you had a cold sore around the eye? And you should be fine. Just quickly, anti-inflammatories, if you guys don't use, please, I'll send them back to you. Immunotherapy, if you don't use it for allergic disease, is wonderful. It may not work, but it's great. And I please advise it. When people have inflammation, I've said FML, sometimes I use doxycycline, and I love high court eye ointment. Zaditin's a wonderful anti-inflammatory for allergic disease. Please don't forget that. Patient has responsibility. They've got to do things. They've got to come back and see you. They've got to tell you if there's a problem. I'm a very strong proponent of that. Patient commits to the treatment, and I tell them straight away, if you don't, this is a hand-holding agreement, if you don't want to hold my hand, there's the door. And I actually say that to them. You've got responsibilities. So so for us, if you've got any issues, if you've got a query and you've got a problem with that, you know what, and you're worried, call me. Just call us. If I'm not there, the girls will get in touch with me and let me know. We Skype, we email, we fax, we see emergencies, because cornea, you've got to be seen straight away. The lady I saw today had botched up surgery 8 months ago and has lost vision in chronic pain, and she's been given steroids and everything else and treated for infections, and she's been fine. And she came in today and I had to stop all that. So you can use steroids and you're not going to go downhill. Do you have any questions at all? Go on.
Corneal transplant, what is made of?
Human tissue, donor tissue. It's all donor.
So there's no rejection or anything? Why the reaction comes?
I didn't show you reactions from a transplant. I showed you swollen before the transplant. So the transplants afterward, there are different types of transplants. And again, rejection rates have dropped off dramatically. I rarely get a corneal rejection now. Okay, and I do lots and lots and lots of transplants. But I'm not going to go into the details of that. That swelling was before the surgery, not afterwards.
Well, it was some chemical burn.
Chemical burn is completely different.
Three transplants.
Chemical burns, that's chalk and cheese. I'm not talking about that, it's different. Sorry about that.
Correct me if I'm wrong.
Yeah.
Corneal transplant, there is no rejection because
No.
it is lymphatic.
No. The modern corneal transplants, we now transplant the layers of the cornea. And there's reasons why transplanting the layers individually drops the rejection rate dramatically. So it's now less than 1%. Okay? I cannot remember. I haven't given anti-rejection drugs my whole career. All right? Then I think I've stuck to time. If I might be 5 minutes early. So we don't bite, we're happy to help, but I actually encourage you guys to participate in it and do it. Don't feel scared. And as soon as you do feel scared, pick up the phone.